Hello, everyone. My name is Solome Tibabu, and I'm excited to do another fabulous episode of the Expanding Access podcast here at Behavioral Health Tech, where we talk about all things expanding access to mental health, addiction, IDD support through technology, health equity, and innovation. And today we have a very special guest, Paurvi. So glad that you could join us. You, as I mentioned earlier, have just such a wealth of experience in so many areas that touch our community. And of course, caregiving, I can't wait to talk more about. So to get started, could you please introduce yourself to our community and share a little bit more about you and ThirdEyeFocus?
Sure. Well, first of all, it's so great to do this conversation specifically with you. So thank you. And for everyone who's able to listen and watch today. So my name is Paurvi Bhatt. I am a second-generation Indian American immigrant. My parents came in the early 1960s. My dad came in 63. 2 years later, my mom followed, and I came a year after that. That's important because this early phase of immigration for this community is important to document. So thank you for allowing my introduction to be from the very beginning. I'm trained in public health, infectious diseases, mainly in the economics of how services are structured through the health system. My first focus was on HIV just because of when I started my work. It was in the early 90s, late 80s. And so a lot of what I've been focusing on has been on how a system starts to expand to a new issue like HIV and what that meant in being a whole of society response. And so much of what I'm biased, of course, but so much of where we are today, I think was shaped not only by the technical side of that work, but more of how the community came together and made sure that, as uncomfortable as it may have been at times, made sure that things were done. And they did get done. And with every new generation, we still are in a moment where we have to get a little uncomfortable to get things done. ThirdEyeFocus. So I spent most of my career in very large institutions in government first. My first roles were at U.S. General Accountability Office, tracking where dollars were flowing based on promises made by the U.S. government and whether we met those promises or not. First for the VA and health promotion within the military. And then very quickly after that, USAID and what was happening with family planning and then ultimately HIV, which is poignant because I've just finished a role, which I'll get to in a moment, and in a chapter of firsts and lasts. And the firsts are very much within that setting and was also last. My last days at the Rosalind Carter Institute for Caregivers also happened to be the last days of USAID. So it's important that we're having this conversation now. And in note that during those early days of AIDS work that I was a part of, we had no therapy yet. What was happening around the world was that parents were coming home to take care of their adult children. Children were leaving school to take care of their parents, making trade-offs because there just wasn't enough access to general health and there wasn't enough money. And if you pause for a second and think about what's happening in society today, we are all coming home to take care of someone who doesn't have access to the things they need. You don't have to be tucked away in northern Thailand or someplace in a village in Africa back in the 80s. That is what this society is being pressured by now. Went through my career in various spots, but Third Eye in particular is now an opportunity for me to advise any part of the system, the health and care system that is trying to bring care closer to home, inside the home with a culturally adapted view, and to be better at how we allocate our capital and our resources so that the measurable outcomes are actually happening and that the voices of the people that are actually providing that care are a part of the solution. So bringing a lot of our care through the normal referral chain, but bringing in community organizations so that they have a reimbursable way to participate. So I'm doing that. On the sidelines of that, I'm also helping particularly women of color who work to be able to bridge the distance between what we're doing at home and is actually building the capability of what we need to be seen as leaders at work. And while I just went through a little bit of my own professional history, I began caregiving for my dad and my mom when I was 28. My father was diagnosed with early onset frontal lobe dementia at 58, and I'm 58 today. And at that moment in time, I had to make a lot of trade-offs. I grew my career, but alongside all of that, as the first full kid in the United States. My parents are the ones that immigrated, but me being the one that was from here, I had to help navigate a lot. And my mom and I lived together for 13 years after my father passed. And she passed away 2.5 years ago. And I'm an only child, and I've remained on my own. No partner, no kids, no siblings, no parents. And I'm now navigating healthcare for myself. There are more single women, particularly women of color, who are navigating healthcare for themselves as we age. So it's a very full circle kind of moment, but Third Eye actually helps track some of these kinds of capabilities that we're building off book, as it seems, and making sure that we're pulling that in as we think about how we can lead more effectively. And so I work on that on an individual level as well. Long intro, I know, but that's the complexity of life.
I was just thinking the intro just can't do justice to the experience you've had. So thank you so much for sharing that.
Yeah.
Paurvi, can you talk a little bit about, this idea that you connected your personal life and care life with your professional life? Did your role as a daughter of immigrants impact both?
It did, and it snuck up on me. So the way that I was integrating it was early on in my career, once it was clear that I needed to be available to my parents. And I was in a global health career, obviously, in learning that I was involved with USAID. I was a part of the economic impact part of what AID was trying to do to look at the effects of HIV at home in households and how trade-offs are being made. And all along, I didn't realize I was making those same trade-offs while I was studying it and helping others do it. And so what I was doing, though, is in my interview process and in my introductions to people, I would call myself a working daughter, mainly out of soft advocacy because there were so many working moms. And they were offered the opportunity, the necessity to be able to take leave throughout maternity leave and even had re-entry to work opportunities. But for me, I needed to make sure people understood what was happening in bringing me onto a team. So when we had cell phones, for example, in the early days of that, I'd make sure my cell phone was sitting on the desk when I was being interviewed. And while I was introducing myself, I would say I'm a working daughter, and people would be kind of curious as to what that is. And I said, my cell phone is on the desk the way yours is, except yours might be because your child might get hurt at their soccer match. Mine is because my father may wander. Either way, we need to be ready. And I just figured if I was upfront and if they still chose me, then there would be no surprises later, that this is really part of what you're choosing for. And that was going on all along, not because of any technical expertise or any point that I was trying to make as a leader, but more just to survive as an immigrant daughter and ensuring that I had what I needed. And that wasn't just because I was a child of an immigrant, but it was because I was a caregiver while I was trying to grow a career I didn't even think of myself that way. I didn't know what FMLA was. I didn't know a lot of things. And lo and behold, even doing all of that, it wasn't easy for me to get what I needed to be able to help take care of my parents throughout various points. I guess I didn't know what FMLA was. Others in my space had to help me understand. Working hybrid was not something that was known even then, right? It's only known now. Even so, people wanted me on site. And I'm from the era when we had faxes to be able to communicate with each other. So the irony of having to be physically somewhere when most of the people that you're working and serving are in an entirely different time zone and country was very difficult. And the only person that saw it was my mom. And she would say, wow, for all of you that are working so hard to take care of the world, you don't seem to take care of each other very much. And that was the first time I was like, wow, we really don't. And so that's how some of this threaded together in advocating and taking time and finding, at the end of the day, it was bosses and managers who were also taking care of people in their lives who would understand and make sure that I had some latitude to do the things that I would do, or my team, colleagues who were my peers, who would help me understand and then fight the good fight on the sidelines so that I would have time and clarity. But my advocacy was real when I would have air tickets sitting on my desk for the next trip because someone with a family couldn't take that trip without being asked. A lot of those things were being built up as it came time for me. I'll end on this. It is the most poignant one, was when it was finally time for me to take leave because my mom was in her final year and I couldn't see it because I was living with her and I was in it. And emotionally couldn't see it and physically couldn't, because the frog in the pot had been going for so long. And a colleague of mine, another vice president at my company, called me and she said, if you had had children, how many would you have had? I said, at least two. I wouldn't have put another kid through what I've been through. She said, okay, so let's look at it this way. The merry-go-round happened to stop here. The overall workforce owes you at least 2 maternity leaves. So take them. And that's when she chose a justice angle to get me to understand that I needed to do something now. And I did. But this is a lot of work to be able to support what all of us are facing now. And all of that came Mrs. Carter along the way in that, and how I finally ended up being the first woman of color and child of an immigrant to ultimately be the CEO of her organization, and the last. Now that we have sunset this organization and merged it with the Carter Center, with an incredible opportunity for a new team to move that through for what this issue is, which is the issue of our time.
Wow. Thank you so much, Paurvi, for sharing that. Just, again, so many important points, and how fortunate that colleague was there to say those things. Really, really important. So also embedded in what you were talking about is this idea of isolation and how that's related to care. Can you talk a little bit about that and what can we do collectively together?
Yeah, it's insidious, right? The way isolation comes up. We're so privileged to be in a time when we can talk about it. So I want to start with the positives. We are in a time at the brink of being able to talk about not just isolation, but the importance of connection. And even that example of the colleague who reached out, she had to make the decision to reach out. There's proactivity to decide to break through someone else's isolation and stay connected. So, and that is something that is, like, the topic itself cannot be over professionalized. So I want to start there too. So yes, isolation. And yes, there are definitions of it. There are clinical responses to it. There are behavioral health responses to it. But in the end, it's the alchemy of a personal connection that helps us get out of it. And that there's no way to overstudy that. You have to actually be in it. So care, the thing with me, because it was a part of my entire journey, and I've been in a variety of access and health issues that are movement oriented, which means you end up with a tribe of people who believe the world is the way you wish it to be also. So I have a unique journey because of that. And so as I spoke about how caregiving was a part of a gentle advocacy, even in my entry to work, and staying in different parts of my work, the isolationism began when it was actually care at home, which was not the caregiving that was happening when I was off site, because I didn't live where my parents lived the entire time of my caregiving journey. Again, as a child of an immigrant, and my dad, who was separated from his family for his career, he was very strong in making sure that I didn't get bogged down, and my mom as well. So I was East Coast, West Coast, Midwest, did a lot of different things. But when care came home and it was time to take care of things at home, very few people understood how that plays out. And my friends were incredibly generous, especially the ones that were local, and seeing it because it was visible. But the isolation became, I wasn't doing the things other people did. I didn't make the life choices other people tended to make, right? I said it at 28. And so in a cultural tradition where by then, classically marriage would happen, children would happen, in-laws would happen, a lot of things would happen, and I couldn't make those choices. I wouldn't make those choices knowing that my parents were my priority. But that left me on a different track in how I was experiencing life when compared to my friends, and not just the others that were in my cultural background, because I was among the older folks because of when my parents immigrated. But even my tribe, my Midwestern tribe, my high school friends, my college friends, my public health school folks, most of them had a variety of different things that they were doing and able to do. I didn't pursue an expatriate life, for example, because I couldn't. I wasn't connected into what is hardwired into community, not just at work because of working moms, but socially in the way people would come together. And when my mom's condition was worsening and we actually had to have care at home, with medical care at home, nobody knew how to navigate that. And that isolationism wasn't only in the lifestyle parts of things. The health system didn't know how to navigate it because it was happening also at the time of the pandemic, but also because these specific pressures and how long running they were at home were new. And the idea of going into facility-based care, while we did it for my father, for memory care, we didn't for my mom. And that was difficult for the system to adjust to because the pandemic, like everyone knows, forced a lot of understanding of what do we do when we need to provide isolated physical care, but not disconnected emotional care for what's necessary at home. In the end of it all, it meant culturally and physically trying to figure out how to get a lot of services at home, from x-ray services to making sure that patient monitoring was happening at home. And ironically, I worked for a company that had patient monitoring. So thankfully, I had some access to it. But that said, the ability for the system to even streamline use of it was difficult. And then the cultural aspects of it were very real. So while I know reimbursement a bit, but while my mom had a Medicare Advantage plan, that was what we had to help her care. While she'd been hospitalized and brought home, some basic things were part of the offering, like 10 days worth of meals that would be sent home for early discharge. So we're in a world today, we weren't then, which was only a short 3 years ago, but we're in a world today where hospital at home is the bright, shiny star that we're all hoping for. Not everybody's ready for it. My home isn't ready. It wasn't ready then. It's not ready now. I don't think very many of our homes are ready for a hospital to come home, nor is the hospital really ready to be home. So the studies are beautifully organized to demonstrate that there's efficiency and effectiveness, efficacy of the outcomes that we're looking for clinically. And they're structured so that we can prove it out. That's what's necessary. Absolutely. But what's not in them are the other people that are involved and are required, which include the family. And so that included me. So back to the first inkling of this with the meals package being sent home for 10 days worth of meals. When we first went through it, when my mom came home, it was, you get to choose, pick what you want off the menu. There was nothing that was vegetarian. The only thing that was there was oatmeal. So I had 10 days worth of oatmeal in a frozen Minnesota garage because I couldn't use it. Here I thought, great, I won't have to cook. And we'll be set, and we were not set. The second time around, there were a few things, but there were Tex-Mex, nothing else. So, and I can tell you right now, if I were to fly any airline today, even 10 to 15 to 20 years ago, I could order not just a vegetarian meal, but one that was ready for a Hindu household. So it exists. It's at scale if airlines are doing it, but it wasn't set up and still isn't for the household here. So multicultural care that's needed at home. And why does that matter? Is that a boutique thing? No, it matters because I have to leave work to come home and do the thing. The hospital and the health system gains margin because they finished parts of it. And the rest of care that needs to be delivered at home is delivered by me. And if that's happening while I'm also cooking and not on a Zoom call for work, who's actually paying for all of that except for my employer that's giving me the grace? And I'm deeply grateful. So my mom's original quote of, you don't take care of each other very well. We're getting so much better at that. But that said, somebody else might be benefiting. And so it's fair to start to ask for the redirection of even more skilled care at home, to redirect some of those margins and bring it back home. We did it during the AIDS pandemic during pharma days. It was a different time, but it was, look, this is a new path of access. So we're all going to have to go with skin in the game and make sure we're able to get things where they're needed because we're in the middle of a major emergency. And if you look today, sure, we see all sorts of pharma meds on TV and TV commercials. They made it back. And we're here again now, a new path of access, which is to bring care home, but allow the rest of us to be able to use our time the way we want and be in connection, emotional connection with the people we want to be with while we're at home, which isn't only carry the last mile of care that the entire health system is supposed to care and bring home, and pay people a fair wage when they are going to do it. Don't count on my paid leave to be able to do it. And that might sound controversial, but I may still choose to be at home, which is what everyone would want, including my employer, at my choice, and what my mom and dad would have wanted, which is time together, not necessarily time with me hustling and running around because the system wasn't able to do it. And now's the time. Now is the time. We are in the emergency. We're just not calling it that because it seems to be a part of our duty to do these things and our desire. Absolutely. But we can't get caught up in that and not realize that we have to call it what it is.
You brought up this topic of reimbursement, and you are starting to touch on this idea of who pays for care and is it even happening? And clearly it's not, and a lot more needs to happen on that front. For those who are not so familiar in our audience about how these things get paid for, can you talk a little bit about what the situation is and where we should be going?
I'm going to start big picture first, because I think what we're all feeling in our day-to-day lives is reflected most in the total cost of care. So the bigger economic picture of what it takes and what we hear on the news or what we might feel in the clinic isn't talking about that. So let me just first start there. The total cost of care is very similar to the description I had about what happened with HIV, right? When kids are coming home from school in the early days because someone was sick, an adult was sick at home. And when you didn't have treatment and you didn't have access to things, kids had to come home from school to help at home. And maybe economically, there was no other way to afford things except to bring them home. Or other parts of the family, other elders in the family needed to come home and help. That was what was happening in the earlier days of HIV. And if you pause, that's where we are now. Every one of us knows someone in our family, if not ourselves, who are facing that. So why is all that happening? There are trade-offs that are being faced across all of that. And the first is someone's home, and that decision for them to stay home or be home was made by a larger health system. And that was made in the best way possible with clinical outcomes, with what's best for a person's health. Absolutely is leading the way. We would hope for that, and it is that, in the best possible way. And I have to keep saying in the best possible way. And that will mean they need to, if they're ready to leave, it's time to leave. Now, when they leave, there are plenty of checkpoints. You can go into a skilled facility, nursing facility. You can go into another form of institutional care. And at the end of the day, you can come home. Now, what is supporting you along the way? A lot of that has to do with whether it can be paid for or not. And whether that's paid for or not is happening through a variety of vehicles that we broadly say is reimbursement, but that can mean a public sector plan based on whether you're entitled for that or not. A lot of debate and discussion about that right now, as we know. And a lot of those, the way a facility makes a decision about what to do is based on all of these different pathways that are funding it, that are actually paying for that hospital, paying for those people. And it's not just one thing that's paying for those things. It's a mix of things. It's just the way things have to be. And because of that, we're affected. So how long we stay someplace, where we go next, when we come home is based on what's available to that facility. What part of it are you contributing to, either through a public sector fund that you have entitlement to or a private plan. And if you're employed, you have what's called an employer-based health plan that has a mix of things that your employer has negotiated with a health plan, an insurance company, and that gives you a certain level of coverage, and that's usually supplemented by what you might be able to afford on your own. All of that comes into play in deciding when and how you move through the system and ultimately at home. And the best circumstances, and if you're older, then Medicare and a lot of other things come into place to finish out the story. A lot of things come into play in those situations. And in some of them, you even have care that is reimbursed and paid for based on any parts of those funnels at home. What's not paid for is whether a loved one, someone who has agreed to be a part of your care system informally, is going to be home or not. What's not paid for is whether all of those inputs are going to be there 100% of the time to make sure you have everything you need. And what is paid for the total system that is official is whether you get better or not in a lot of ways. It's valued, right? So when you hear things like value-based care, or you hear, did the outcome happen or not? Well, if making up something, but if I'm home because of a chronic condition that keeps my blood pressure high, and that led to a cardiac event, all at the end is if my blood pressure finally got managed and my cardiac event was healed, That was the outcome we were looking for. All of those different factors that were involved have succeeded, except for the fact that if I had, my niece who's coming to take care of me, her time to ensure all that got done, her time to manage that process, because it does take managing it as if you had a project manager on your team at work. That is what that job is 100% of the time. Her navigation to convince me to take my med on time, all of the things that she might be doing with me at home is not paid for. And if it's paid for at all, it's paid for by her employer, who's letting, if she's lucky enough to have paid leave, for her to be able to have that time with me. But that has nothing to do with my care. And if I'm successful at the end, that other system, all of those other folks that are involved in the payment of it, they've got the win, right? Because I turned out okay at the end. But her employer, they get the win because she's staying with them because she's lucky enough to have it, and she's a high performer and she's going to do great work, but she's feeling the stress and pressure to be able to do all of that. So hopefully that helps in saying it's complicated, but at this moment in time and where we are, we can't get away with just saying it's complicated. Every single one of us, especially those of us who work in the system and who lead in the system, all know the pressure of Sunday night because we're doing all of this. My niece, using that same example, will know the pressure of the weekend and the evenings of getting everything set up. But shame on even me, when I was in the system, that Monday morning, I may have been faced with any number of decisions that could have changed my own Sunday night when I was taking care of my mom. And I didn't make those decisions. I didn't even bring this up in a staff meeting to say, hey, is anyone else going through something? Can we support each other? Or even more importantly, that decision we just made, would that have helped me? And if it didn't, if I could honestly say, you know what, it wouldn't have, then to throw a flag on the play and start again. And that's where we are now. In order for things to change, is to let the compartment fall between what we're doing at home and what we're doing at work, which is not the norm of this culture that we're in. But there's no way, one, that we can help each other. There's no way that we can be connected. Back to isolation and what is it going to take? We can't over professionalize what these things are. Even the caregiver space is, slowly becoming so over professionalized that we can't admit that we are one and we've got to do something no matter where you are in the economic pyramid. Even for my situation with my mom, people are like, oh, well, you're insured. You've got resources. You can do it. And I had to very baldly say, I can pay for it, but the it doesn't exist. That is the issue now. The it that we need doesn't exist. And if it was an emergency and someone rang the bell the way we have on other things that didn't exist, but we had to figure it out, we would have it by now. But we're just in a situation where the system that we have, thankfully we have it, was created by a different generation who saw that the it didn't exist and created it. And we're here now, and we cannot allow this moment to go by without creating what is necessary. And tech alone is not going to get us where we need to be. Tech is keeping us isolated. We have to admit it. When WHO puts out a commission that is to explore social connection, and then even has its very first resolution, so the bells are ringing, the first resolution to say we are in trouble. We are isolated and it is negatively affecting us. And we need to now resolve that we are going to fix this in all countries across the world, starting with this one. We have to hear it. Last August, I should say, August 2024, CDC, MMWR, towards the latter half of the month in August, released data. Now, I come from the HIV era, so the first slide of anybody who talks about the history of AIDS knows the first slide is CDC, MMWR. There's a pneumonia spreading among 5 men, right? So that's why I jump when I see something like that. So what happened with CDC last August is 13 out of 19 health outcomes that were being measured, looking at caregivers versus not, were disproportionately worse for caregivers than those that are not. 13. Some of them were behavioral, some of them were emotional, many of them were chronic conditions. The bell has rung. The act of care in and of itself is negatively impacting those who deliver it and positively impacting the recipients of those who get that care. We already know that in the health industry because health workers themselves suffer so much. But now I'm infectious disease trained. So if I were to look at it from an infectious disease perspective, that factoid, the 13 out of 19 now says this is spread into the general population. Now, if we put that together that way, we all just have gone through a COVID moment, no matter how you view it. We know what that meant. We all changed and we addressed it somehow. That's what I'm saying. We cannot sit now with a tinkering on the sidelines. This is now the emergency that it is.
Thank you. I know that wasn't even an easy question to answer remotely. So great overview.
I hope it was clear.
Absolutely. Well, here's another easy question for you. You've spent so much time in philanthropy, and this word impact gets thrown around quite a bit. What does it mean exactly? And is it overused?
It is overused. It's a 5-letter word. It's become rhetorical, and we're in a place in society now where we don't ask follow-up questions easily. And so we all think we know what it means in the world that we're in, and it's hard to slow our roll to really ask. I mean, it's an important word, and I think when it is used, it's used with intent and generally with positive intent. But unless we ask for clarification, we don't know what that intent is. So the way that I'm trained, impact means it's been measured and proven, and that it's moved to impact more than 1 or 2 people, right? So you might have to demonstrate an outcome somewhere, and that outcome is something that is tied to the original intent of what we were trying to improve. And it's been measured in some way. It doesn't have to be perfect, but it's been measured in some way that is advancing us. And the impact of it then is that you're moving it beyond where you first tried it out. So you're moving it to scale. And everything that's happened in the disruptive world is built on the belief of that, but we're skipping past the impact part of it, the outcome part of it, the measurable part, to say, wait, before you go any further, are we sure? And that is very difficult, I think, for folks to settle in on. The way that plays out in the way that I've been trying to look at it is, even whether it's the mission of a company or a nonprofit or the mission of anything, your own life. Usually when you look at that, there are words in what we believe that actually mean something. Like, how do I know that I'm actually making a difference in that way? And pretty quickly you can say, well, I would be sleeping better if I felt that my well-being was better, or pick anything, pick any word, right? We see all sorts of things about being alone. Well, there are ways of demonstrating and measuring whether you're alone or not. We shouldn't let anyone off the hook in demonstrating whether that's changed or not. And really starting to unpack from that mission statement, what would be the 1 or 2 things that we could demonstrate every year is getting better, and to continue to work towards that. It doesn't have to be perfect, but to continue to work towards that. So when we say impact, then we can actually do the stress test on ourselves and be able to look at each other to say, yes, I am having an impact, and here's why. So for me, even if I think about what am I going to try and do with my own time, it'll be more conversations like this, or someone else being able to say, you know what? I actually say that I'm a former caregiver and a current griever now. I put that on, I have chosen to put that on my LinkedIn now, so that other conversations can begin. Am I trained in something there? No, I'm trained in exactly what I've been describing. But now it helps me start to ask myself, did I answer the question I needed to in the next board meeting I'm in? Did I actually bring up the topic that needed to be brought up? Because if the outcome is to be whatever it may be, it's on me to make sure that I'm asking, all right, well, have we really reached that? It's not a comfortable place to be. Most people don't want that, because once you start asking about those things, accountability follows very quickly. But that's why we're here. And that's why we need to be able to be strong and brave in asking those questions. And 9 out of 10, we're not the only ones wondering about it. So the impact piece, we get away with a lot, like, oh yeah, I'm having impact. Great. Oh yes, have you had an impact? We have. Here are 3 studies that show it. It's like, no, well, explain to me how that's the case, and help me understand how that is actually connected to why we're here. Those are really important questions, because resources, from time to intent and focus to money, are all very thin. And we all are trying to raise our voices in a direction right now, and we're seeing it everywhere. And if we don't slow down and make sure we're aligned on what impact means, we're not going to get to where we need to be. And we can't get lost in individual storytelling alone as if that is impact. It's not. It has to be connected back to decisions and results and outcomes that actually are material to where we were heading.
So wonderful. Thank you so much, Paurvi. I wish I could ask you dozens more questions. Super insightful as well as always. Anytime I talk to you, I learned so much. And if I could just wrap up with one more question, I think is really powerful for the leaders in our audience, which of course we're all capable of being. What do they need to know now as we reimagine connection and care moving forward?
I'm going to focus on connection. So for everyone who is leading, I think one of the most important things I ask is not to worry about titles, not to worry about image, not to worry about influence or hustle, but to slow our roll and have eye contact again. Never before, I can say this as an introvert, one of the most positive things that came out of the pandemic for me is that these screens opened up. And as a result of it, never before have we shared eye contact to the extent that we do now. And that very important thing is how we lead forward, looking each other in the eye and saying thank you and being very specific as to why, no matter who is in the room. So the first part of where I would lead with this answer is on connect. And don't think that the cool thing, which might be something that tech is going to spin up for us, is what we've always been looking for. I'm not dismissing any of that. I think it's really important. The whole point of my saying Zoom is what might have made us actually be more connected. But at the end of the day, slow down and use the opportunity that technology offers to liberate time and freedom to have the human connection that is necessary. There's no other way to explain how can we feel so alone at a time when we're technologically more connected, except we have not redirected our time to truly be together. So as leaders, unlock time, unlock the flexibility and the freedom of the use of that time. And leading from wherever you are, speak up in that you need that time and be very intentional as to why and for what purpose. At the end of the day, none of us wants Rosie the robot to bathe our mothers. As cool as it seems that we're going to have robotics at home to help take care of us, not until it's your home. Not until it's your home. And then you realize, oh no, Ring cameras were not created to voyeur on our parents or on us. They were created for safety outside. So be careful. And the decisions that are made that are to make us more efficient someplace else, they're not necessarily making us more efficient in the human connection that makes us happily here. I think there was someone who said that the true disruption and innovation is when we disrupt ourselves. If we're going to be innovative, we have to disrupt ourselves and face each other again, the way we do now on camera.
Excellent. Thank you so much, Paurvi. Again, as always, just super insightful and grateful that you could share your experience and expertise and just your incredible journey with the behavioral health community.